Well, greetings everyone, and welcome to the EKG case for the week of June 9th, 2014. I'm actually coming at you from Hong Kong at this moment. I just arrived a little while ago into Hong Kong, and it's great to be here. In particular, it's great to be off the airplane. I guess maybe this week should probably have been more appropriately devoted to PEs on the EKG website, but I've got a slightly different case. And again, I hope to see some of you here in the ISEM conference that we're going to be doing in just a couple of days. So on to the case for this week. This is actually sent by Dr. Sean Fox, who is a former superstar residency graduate. He's boarded in emergency medicine and pediatrics and doing some great teaching and academic work at Carolinas Medical Center in North Carolina. Sean actually sent this case to me almost a year ago, believe it or not, and it came to mind because of something I was reading on the airplane. I was trying to get a little work done on that long 15-hour flight, and one of the things that I happened to be reading jogged my memory of this case, and so that's why we're doing it a year later. So this is a 33-year-old woman that came into their emergency department complaining of chest pain. Now, first of all, 33 years old, right? Sarcastically, I always bring up the point that young people don't have MIs, and it is totally sarcastic because if you've been watching this EKG series, you know that I love showing cases of young people that are having disastrous EKG findings, maybe MIs or PEs or other such things. But in a 33-year-old woman with chest pain, you've probably got a pretty low suspicion for anything bad. Maybe the first thing you're going to be thinking is gastroesophageal reflux disease, right? Well, that was the sound of me slapping myself, and that's exactly what I want you to do if you ever think of GERD as the first diagnosis in somebody with chest pain. So let's definitely get rid of that. Even in a 33-year-old, you don't think of gastroesophageal reflux disease or peptic ulcer disease. We're in emergency medicine, so we're going to think about the killer diseases. Well, ACS, pretty low likelihood, but she's, got chest pain, and maybe she just arrived here in Hong Kong also. So anyway, she might have a PE. You're going to think about dissection in anybody who's got chest pain. Again, 33 years old is kind of a low risk issue. And then you might be thinking about pericarditis. And there's some other killers you might think about. Tension pneumothorax, but there's no trauma. Maybe esophageal rupture, but I didn't give you any history, or I didn't hear any history of retching or anything else like that. Let's move forward. Whoa. She is in her third trimester of pregnancy. So if we go back to our list, now maybe we're thinking a little bit more about dissection and maybe a little bit more about PE, right? Given that she's pregnant, third trimester we know is a higher risk for dissection, thoracic artery dissection. There's no past medical history, no cardiac risk factors. We're not trying to hide anything from you. She's a healthy person, no early family history, no crazy cholesterol issues, nothing. She just happens to be in her third trimester of pregnancy. So maybe PE and dissection are kind of moving up the list just a little bit. Well, her pain radiates to the back. So let me go back a little bit and put an extra circle around dissection. Although, how many of you have ever seen a patient come in saying that their chest pain radiates to the back, and then they have the gall to rule out for a dissection, right? It happens all the time. Half of our patients say that their pain radiates to the back. And I don't know why that is. It's such a non-specific thing, but we've all been taught. Now, when the pain radiates to the back, you've got to think about dissection. And also chest x-ray is normal, which means very little. If she had a wide mediastinum, then of course we'd worry more about dissection. But in this case, she's got a normal chest x-ray, and that should not lower your concern. You still have to be concerned. If she had a pleural effusion or atelectasis or an elevated hemidiaphragm, then maybe you'd worry more about PE. If she had evidence of heart failure, you might worry more about myocarditis or MI and so on. So where do we go from there? Well, of course, this is an EKG video series, for God's sake. So we got to get an EKG. And here, whoa, here's the EKG. This is not so good, all right? There's big time ST segment elevation. There's a little bit in the inferior leads, but mostly what's catching our eyes is this awful looking ST elevation across the precordial leads. It's almost, well, it's definitely straight in nature, and we know that's concerning. We're a little bit happier when it's concave upwards, but we get really worried when those ST segments are straight. And here it's almost looking like it's starting to tombstone just a little bit. Well, she's only 33. She's got chest pain. This can't be an MI. You know what? Let's repeat the 12 lead. Maybe this is just some artifact or whatever. Here's the repeat. Her scary-looking findings are not going anywhere, and she still has this concerning ST segments or a straightening of the T waves in the inferior leads also. Is this 33-year-old having a big MI? What in the world could this be? Well, anyway, what Sean's colleagues did was they got a troponin. It was slightly elevated, a troponin of 2, and I don't know the units, just bear in mind it was slightly elevated. Really means very little. So they got cardiology and OBGYN involved, and everybody got their heads together, trying to figure out what are you going to do with this? You're going to take this 33-year-old woman who is in her 3rd trimester of pregnancy, or you're going to take her to the cath lab. And that's exactly what they did. And it turned out she had a left anterior artery dissection, not a thoracic dissection, but an LAD dissection. And when they got the second troponin, it came out 30. And again, I don't know what the units are, but any lab that goes from 2 to 30 has got to be bad, right? So she had an acute MI, and the cause of her MI wasn't the typical ruptured plaque from atherosclerosis. The cause of her MI was a coronary artery dissection. So there's not a lot to the EKG in this case, but I just did want to spend a few minutes talking about acute MI in pregnancy. And the reason why this is important is because MIs do happen in pregnancy. Pregnancy is a slight increased risk factor for acute MI. Again, you're not talking about the risk of as high a risk as somebody who smokes and has diabetes and has high cholesterol. Pregnancy does increase the risk a little bit. And in the 3rd trimester and for the first 6 weeks postpartum, it is in particular a higher risk factor. And the maternal, I spelled maternal wrong, sorry about that, but maternal mortality is not insignificant, neither is the fetal mortality. Both run around 10%. So if you miss this, even if you make the diagnosis, but there's a slow response, these patients have a really bad outcome. And I have to tell you that in the past, 5 or 6 years, this is about the 4th pregnant woman, most in the second half of pregnancy, all of them, I think, who has had an MI, and one of them was a case that I saw, and unfortunately 2 of the cases I know of were delayed or flat out missed MIs that occurred during pregnancy. And in both of those cases, they occurred because these are young women who didn't have any other cardiac risk factors or any other concerns, and so the last thing that the docs were thinking was that this could possibly be an MI. Women, especially late in pregnancy, get bad reflux oftentimes. Oh, there's that slap again. And so a lot of times the first thought in people's mind is that this is probably just pregnancy-induced reflux, but you've got to be very careful. By the way, one of those 4 cases I mentioned, they didn't even get an EKG by the 2nd and I think even the 3rd visit. It took 3 visits before they finally got the 12-lead EKG, and then mom ended up dying from a massive anterior wall MI. All right. Well, why is pregnancy a risk for early MI? There's a handful of theories for why this happens. I'm not going to go into pathophys here, but it's increasing in incidence over the past 10, 15 years, partly because of assisted reproduction, and women are getting pregnant at older ages, and the older people get, the more likely they're going to have atherosclerosis and all of your other risk factors. So pregnancy is not just a 20, 25-year-old type of thing. We're seeing women in our hospital, and probably in your hospital also, we're seeing women in their late 30s that are routinely getting pregnant, women in their early 40s that are getting pregnant. And unfortunately, as we get older, atherosclerosis becomes a bigger issue, including in many of these patients. And so we're going to be seeing, a lot of people are predicting we're going to be seeing more true MIs in pregnancy. Well, the plaque rupture and atherosclerosis accounts actually for less than half of the MIs in pregnancy. There's a handful of other things that account for MIs in pregnancy, but probably the most common cause of MI in pregnancy is coronary artery dissection. Who would ever think of a coronary artery dissection in most patients? Well, in pregnant patients, coronary artery dissection becomes one of the most common, if not the most common cause of MI. Again, there's a handful of pathophys reasons for why this happens, hormonal changes that weaken the vessel walls, the shear forces of third trimester, and also many of these patients have previously undiagnosed underlying connective tissue diseases like Ehlers-Danlos syndrome and other such things. Again, I'm not going to go into the basic science or the pathophys here, but just be aware that, again, MIs do happen in young women, and it's not always atherosclerosis. So even if somebody is living a good, healthy lifestyle and is at minimal risk of atherosclerosis, this is still something that will happen in many of these cases. And what's the risk factor there? Well, probably, I like to say, the biggest risk factor in all of emergency cardiology is nothing more than simply bad luck. And you never know who's going to have bad luck, right? People don't come into the emergency department and say, yeah, I smoke cigarettes, I've got diabetes, and I've got bad luck. I wish they did, but you just don't know if their risk is the bad luck. So you've got to think about this early on and get that EKG and maintain a good suspicion for this. Now back to EKGs, there are some subtle EKG changes that can occur in pregnancy. I didn't know about this before reading about this article. By the way, the article is from Cardiology Clinics. It was published in 2012, and the article's title is Chest Pain Syndromes in Pregnancy. It's a fantastic article. Again, Cardiology Clinics in 2012. There's an issue that was entirely devoted to cardiovascular disorders in pregnancy, and this was a really great article. And I never heard about this before, but there are some EKG changes that occur in pregnancy. You can have axis changes. You can sometimes get a small Q wave in lead 3. Actually, that can occur even outside of pregnancy. You can get nonspecific T wave inversions that can revert after the pregnancy or progress during the course of the pregnancy. So again, nonspecific T wave inversions. And another interesting thing is that for some reason you can have an increased R to S ratio in V1 or V2. In other words, a tall R wave in V1 and V2, which can mimic old posterior MI. Or maybe you're going to look at that EKG and think that the patient has a prior history of pulmonary disease, like COPD. Right? And there's also some data indicating that pregnant patients during the C-section, the induction of anesthesia, can cause some ST segment depression. Again, I didn't get into too much detail there regarding the pathophys, and I'm not going to here, but there are all kinds of EKG abnormalities that can occur in pregnancy. Notice ST elevation is not one of them. So when you see ST elevation in pregnancy, again, it's not a normal variant, and also it's not reflux. Oh, there it is. My face is going to be really sore by the time this is over. All right, how do you treat these patients? Just, again, really quick. I think this is one of the scenarios where you don't necessarily need to run around like a chicken with its head cut off trying to meet your 90-minute mark. I think this is one of the scenarios where it's definitely worth waiting an extra 5 or 10 or 15 minutes, if necessary, to get OB and cardiology on board. All right? Don't do this on your own. These are complicated patients. Get OB and cardiology on board. Most of the care is fairly usual in the emergency department. You're just going to go ahead with the aspirin. There is a little bit of debate and controversy regarding whether these patients are safe staying on aspirin long term or for several months or so. But in the emergency department, give them that one dose of aspirin. The one dose is not going to hurt, and it'll probably help. PCI definitely is, like with everything else in every other patient group, PCI is preferable to lytics, largely because if they're in the peripartum period, if they're close to delivery, then lytics on board are going to cause an increase in hemorrhage. And also, because of our concerns for coronary artery dissection, ideally you don't want to give lytics. But if you have no access to a cath lab, lytics are an acceptable treatment for the STEMI. There's actually very little placental transfer of streptokinase in TPA. Now, this is a really tough scenario if you don't have PCI available, because when you see that STEMI, one of the things you've got to consider is the possibility that this is a coronary artery dissection. And if lytics is all you have, that's, again, a tough decision. Do you give the lytics hoping it's not a dissection and that it's a true plaque rupture? Or should you hold off on the lytics and find some place to transfer the patient? Again, that's why I say that you've got to coordinate this decision with OB and cardiology. Don't do this on your own. And the heparins are certainly okay. So I don't want to get into too much detail here. Again, the article went into a lot more detail for the emergency and also the inpatient management of acute MI. A lot of that is outside the spectrum of what we want to do, but just some key points. Remember, get that EKG. Chest pain in pregnancy is not just a matter of reflux. And also, bad chest pain in pregnancy, you don't just think about PE and dissection. You've got to think about the possibility of true MI, even though these are young, otherwise healthy women. They are at increased risk. I've seen 4 cases in about the past 5 years, 2 of which were missed, and one of those patients actually died because nobody thought early enough to get the EKG. All right, coronary dissection, keep it in mind and get your cardiology and OB folks on board before throwing the lytics or even the heparin at those patients because of the risk of the dissection. And remember that maternal and fetal mortality are high, so treat these patients aggressively, rapidly, but with the help of your OB/GYN and cardiology folks. And more than anything, I just want to say, get the EKG. Too often, these young women don't get EKGs because nobody's worried about the heart. You've got to worry about the heart, even young women that are pregnant. All right, so I hope that was helpful, and I look forward to talking to all of you back next week when I'm back home. For those of you that are out here in Hong Kong also, I hope your travels have been safe, and until next week, take care.